So in children with IgA nephropathy, we believe it happens for similar reasons to why it happens in adults, and that's to do with the immune system overreacting to this immunoglobulin A molecule. And for some reason, the immune system produces an abnormal IgA, and that's detected by your body as being abnormal, and you launch this immune response against it. And what we see is this circulating abnormal IgA and also immune complexes where they bulk together, and that can deposit in the kidney. And in the kidney, we see similar to what we see in the adult kidney biopsies, where we see lots of this IgA deposited within the glomerulus. Interestingly, in children, we usually see it around the age of kind of older primary school, early secondary school age, about 10 to 11 years, but it can happen at any age. And in particular, we usually see that the teenagers are slightly worse than the younger children, and this might reflect more like adult disease. It's usually picked up by very visible bright red blood in the urine, which is often similar to what you would probably see in adults presenting with the disease. But what's slightly different is that most of the time it's triggered by upper respiratory tract infections, so coughs, colds or sore throats. And in children, we usually see with lots and lots of viral illnesses that this is quite a common finding, and that children with each upper respiratory tract infection will have a flare-up of their IgA nephropathy. We also see that the teeth and dental hygiene can sometimes be a trigger, and also recurrent tonsillitis. And if a child was really troubled with recurrent tonsillitis and it was causing them to be quite unwell frequently, then we do consider tonsillectomy. We'd sometimes see gut triggers, but we don't know entirely why we don't see it as much as what we would perhaps in adults. So some of the key differences, we often see a delay in the diagnosis. Lots of people don't realise that children can also get IgA nephropathy, and we usually see children that have been to perhaps their GP or A&Es with blood in the urine and have been diagnosed with urine infections and given multiple courses of antibiotics, assuming that it was a simple urine infection and that the antibiotics would treat it and it would go away. And often we see that this is a persistent finding until they eventually get through their GP to a local paediatrician and then eventually referred to a paediatric nephrologist, where they have investigations. And so it can take a little journey before the patient actually reaches the diagnosis. And sometimes we have to help patients unpack that journey and understand why it hasn't been detected earlier. And that's mainly because it's actually relatively rare in children to have IgA nephropathy compared to normal childhood conditions. Interestingly, when we do the kidney biopsy, and we do it in a similar way to adults who have the biopsy, apart from usually we put the children under a general anaesthetic for it, we usually see much less damage in the kidney and much more inflammation. So usually the kidney is packed full of inflammatory cells, but we see a lot less scarring and damage. And that therefore gives us an indication that we want to try and calm the immune system down fairly early on in the treatment and fairly quickly, so that we can try and prevent any damage happening, because we want our children's kidneys to be healthy as soon as possible for as long as possible, so that their kidneys will last them into a healthy adulthood. We often see that children actually respond relatively well to us calming the immune system, and when we look in the literature and look at studies, we can actually see that children often have a better long-term outcome in how well their kidneys do in the longer term. And this is probably related to the fact that we don't see as much scarring in the kidney compared to what adults might see with IgA nephropathy. We have a small group of children who also have a similar condition called IgA vasculitis, where they present with a rash, but the kidney biopsy can be very similar. And some patients can fluctuate between having IgA vasculitis with the rash and having episodes of IgA nephropathy with just bright red urine and no rash. And we see some patients will flip between the two, or some of them will present with one and then progress into the other. And it might be that these are related conditions, although we don't fully understand why some patients will present in one way and not in the other way. In children with IgA nephropathy, we worry about those who have lots of protein in the urine. We worry about those where their protein is so heavy in the urine that their blood protein levels will fall and they will therefore get swollen. And we see this fairly commonly in the severe cases of IgA nephropathy. So if you were to get swollen and you begin to get swelling in your face, a bit like the picture of this little boy here, around your ankles, then we worry a bit more about the longer term kidney future for those children. And we also worry about the children where their kidney function is abnormal, and certainly those that stay abnormal when we've tried to calm the immune system down. And so they're the group where they will be under a paediatric nephrologist and will be seen fairly regularly and usually have fairly strong treatment to try and calm their immune system down at a very early stage. So the treatments that we use are similar to treatments in adults. The focus predominantly is trying to reduce the amount of protein leaking from the kidney, and we use medications like Professor Barrett mentioned, including the angiotensin receptor inhibitors. We use slightly different named drugs within that brand because we only use the ones that are available for children, so the ones that come in liquid form, because children often can't take the tablet forms that you might be able to take as an adult. But essentially they're working to reduce the kidney leaking from the protein to try and calm that leakage down. But we also treat children fairly early on with immune medicines to try and calm the immune system down. And for that reason, we often act depending on the biopsy results. If needed, we also treat high blood pressure if children have high blood pressure, and also treat swelling where they might have extra swelling and we need to use medications to allow them to wee out extra water to try and cope with that swelling. We know that the current medications, particularly high dose steroids, have lots of side effects, and we've listened to patients in similar patient groups to this event where patients have told us how much they dislike the big doses of steroids because of the side effects that they have. And these side effects can include weight gain, they can include changes in your appearance, they can include longer term side effects for bone health and your heart health as well. And we're desperately trying to look towards better ways to calm the immune system that doesn't rely on big doses of steroids so early on. So what's the future like for children with IgA nephropathy? As Professor Barrett said, in adults, we still need to learn more about the disease, and that's exactly the same in children. We're continuing to learn all the time about this, and we need to understand what's important for our patients. So what medications do you feel work? What medications do you want to use, and what medications just don't work, or do we need to work better on? We need to find and test new treatments, and it's great to see some of the research trials evolving so that these patients will be able to have more options, and we will be able to tailor the treatment as to what they need. But we as paediatricians need to push for children to be allowed in those research trials so that the minute an adult is allowed a very new treatment which might be the best for their disease, we need to push so that children are also allowed into those research trials so that children are allowed access to the new drugs as well, and they don't have to wait the 5 or 10 years for the regulations to approve everything before a child can get the best drug for them. And that's something that we feel very strongly about, and we try to push the pharmaceutical industry to promote at an early stage. So I just want to finish with this slide talking a little bit about coronavirus in children with kidney disease. I'm not sure how clear these will project, but they are available on the Renal Association website. And this is our very recent updated shielding guidance for children and young people with kidney disease. And essentially we've reclassified things using the data that we have from across the world, which suggests that children who get coronavirus, even those with kidney disease, are very mildly affected. And so therefore our high risk and our extremely vulnerable group are patients who've only very recently had a kidney transplant in the last 3 months, those who are on very high doses of immune medicine, so such as those that are being given through a drip or a vein in hospital, very high doses of steroids or the toxic medication cyclophosphamide. The medium group, the yellow group, are patients who have had a kidney transplant over 3 months ago. If you're going to hospital for dialysis, so for hemodialysis, and you're a child, if you're on a moderate amount of medication, so 2 or more immune medications, or if your kidney team feel that you're at increased risk because you might have another condition going on, then what we would say in the medium group is to maintain the social distancing, but it might be that your parents can return to work or that your siblings can go back to school if that social distancing can be maintained. And in our green group are patients who are on dialysis at home and those who have chronic kidney disease but don't need dialysis and who are not on many immune medications. So our guidance for children is actually quite different to coronavirus guidance in adults, because we see that children as a whole are actually relatively protected from this, and it's a very mild condition. And so we've traffic lighted our guidance to try and give parents and patients some idea of where we think their level of risk is. But again, there is an individual personal approach to this, and the guidance does change fairly quickly. And we're also aware that the guidance does change depending on where you live, such as Wales and Scotland, which might be different to people who live in England. So essentially that's there as a bit of a template, particularly for children with kidney disease, but do consult your kidney team if you've got any queries about that. And we might be able to pick up more on that on the panel discussion if anybody has any more specific questions. So I'd just like to thank you for listening to the slides, and hopefully we'll be able to get some interaction through the chat function and the panel questions and answers later. And I'll hand back to Professor Barrett. Thanks.